heart and bread of neonatology, and we need to know this in detail so that we can improve the outcomes of our babies. So we try to concentrate on the must know, the difficult to know, and also some interesting things which we can learn from neonatology. So we will start off with the first one, and there'll be some learning also. These are not exams. So please write your answers in the chat box so that we can see what you're writing. Where are they writing? They're allowed to write in the chat box, Pratima?
Yes, sir. Yes, sir. They are with us in the same on the same platform, and
Okay.
they can type in the chat box. Hello,
Okay.
everybody.
So can we hear from all of you? Hi.
Yeah, can you just type
Hi
hi?
in the chat box. Yeah, I can hear Govind. Yes. Thank you. Thank you. Yes. So that means there are so many. I think we have 90 attendance, and I'm sure out of this 80 must be the students who are attending. So we go on straight with the first OSCE. So I'm sure many of you are familiar with this curve, with this figure. First, let me please try chat in the task box. What is this curve? What does this curve represent? What does this curve represent? Lung volumes. Yeah, I think Kushi, you're right. Very good. Alpana, you're also right. Very good. So I think many of them already know about it. This curve represents the PVR in relation to lung volume. How the PVR changes with respect to lung volume. You can see here, the lung volume is less than the FRC, then your PVR rises. If it is more than the FRC also, the lung volume PVR will rise. So the bold red line tells you that at either spectrum of the lung volume. So in MAS also you'll have high PVR, in RDS also you'll have high PVR. Now that's one thing. Yes, wonderful. Now let us find out what are this dotted blue and red line. What are these dotted red and blue line then? So overall lung PVR least at FRC is what is reflected by the thick red line. But what are this dotted blue and red line? What do they represent? Yes. Um, mm, oh, no. I think, yeah, very good. Akshay, you are right. Yeah, little more detail, Akshay, if possible. Nikhar Somani, you are also right. So you have two kinds of blood vessels in the lung. One blood vessels are sitting in between the two alveoli. The other blood vessels are in the junction of the alveoli. So extra-alveolar between the alveoli blood vessels. So obviously, if they are between the alveoli, when the alveoli expand, the between alveoli, the blood vessels or capillaries between the alveoli become compressed, and in hypovolemia, when the lung volume is small, this between blood vessels will compress. That will increase the PVR as seen in the dotted blue line. So the other one are the interacinar, or those blood vessels which are not between the alveoli at the junctions of the alveoli, which are extra alveolar capillaries. When the alveoli expand, these acini or these capillaries which are at the junction, like what you can see in the top curve here, they also open up with the alveoli. So extra alveolar blood vessels, so they are the ones which get compressed when the volumes are small. So when the volumes are small, like RDS, you will see the interalveolar vessels get compressed and the PVR will rise. and that is as seen in the dotted line. Extra-alveolar blood vessels will compress when the alveoli open up, as you can see in the dotted red line. So like in MAS. So the combination of this is what we see is the red line, which is not dotted, or the thick red line. So this is important for us to remember that the FRC is the lowest, or the PVR is lowest, and the FRC. Now that is a very important thing which all of us should know. But how do we know that we are sitting at the optimum FRC? What are the clinical signs which tells us that you are sitting at the optimum FRC? So you know that optimum FRC means lowest PVR, but how clinically we can know that this baby is having optimum FRC? Wonderful. Yes, please go ahead. Wonderful. Good. So I think all these people have read well. Wonderful. So one thing is when you have low FRC, you'll start seeing retractions. Yes. When you have low FRC, you start seeing retractions, grunting, high oxygen requirement. Wonderful. And at the higher FRC, what will you see then? If FRC is high and it is compressing the interalveoli capillaries, what will you see? You see from the child side, the chest is hyperinflated. So you need to look at both. Optimum means both under alveoli and excess alveoli should not be there. Wonderful. So if your chest is hyperinflated, your venous return will come. You will also see circulatory effects like capillary filling time could be prolonged, your tachycardia could be there. And from the side, you can see that the chest looks hyperinflated. Another method is looking at the chest X-ray. Not really shock, but early phases of shock, like what you see with hypovolemia. Okay. So wonderful. I think many of them could get the right answers. So only we could give you chocolates, but yeah, we can give you online chocolates. So yeah, many people have done well. Yes, X-ray, 6 to 8 spaces. Less than 6 spaces is underinflation. More than 8 spaces is excess inflation. You can also look at the dome of the diaphragm. It is flat or whether it is curved. If it is curved or if it's flat, you know that you are underinflated or excess inflated. Okay, so wonderful. So that's it. So that is a PVR curve. The blue dotted high PVR at low lung volume, and the red dotted high PVR at high lung volumes, interalveolar, extraalveolar. So that is what we see, that you have mostly signs for underinflation, but you need to look carefully at the signs for excess inflation also. So be careful about that. Over to you, Swati.
Thank you, sir. So we will move on to the next question now. All of you can see this graph on the screen. So could you all tell me what are you seeing on the screen? What is this graph? Yes. Yes, I think all of you have identified it correctly as oxygen hemoglobin dissociation curve. So basically, this is a oxyhemoglobin dissociation curve, which tells us about the relationship between the arterial PaO2 and the percentage hemoglobin saturation. That is the partial pressure of oxygen in the blood and how full or saturated the hemoglobin is. Now, next question is, what is P50? What is P50? Yes. At which hemoglobin is 50%. Yes, I think all of you have read. Very nice, very good. So P50, as all of you have correctly said, it is the partial pressure of oxygen at which hemoglobin is 50% saturated. So what does it actually mean? It actually, you can think of it as the measure of affinity, or how tightly hemoglobin hugs oxygen. If P50 increases, what will happen? It means hemoglobin is letting go more easily. And if it decreases, it is holding on tighter. Okay. So P50, as all of you have correctly mentioned, it is a partial pressure of oxygen at which hemoglobin is 50% saturated, and it is actually a measure of affinity. Now, next two questions are regarding the factors which cause the oxyhemoglobin curve to shift to right and the factors which cause shift to left. Yes, hypercarbia. Okay, great, very nice. I think all of you are masters in this curve. That's excellent. It's really good to see all of you are interacting and writing the right answers. So yes, the curve will shift to right whenever there is hyperthermia, there is hypercarbia, high CO2, acidosis, etc. So why right shift means that the hemoglobin becomes more generous. Whenever there is a shift to right, oxygen will be released easily. And whenever there is a shift to left, that makes hemoglobin more stingy. So whenever the graph is shifting to the left, it means that oxygen is loading easily, but unloading becomes difficult. So it will happen in conditions like hypothermia, hypocarbia, and alkalosis. Yes, I think all of you are correctly mentioning the shift to right, and the shift to left will happen in hypothermia, hypocarbia, alkalosis, anything where oxygen loading will become easy, but unloading becomes difficult. So hemoglobin holds on to oxygen so tightly that it is actually harder for it to release. So this we have to remember, because there is clinical implication of this as well. All right. So yes, I think most of you have answered this very well. Shift to right and shift to left. Now the last questions regarding this graph is, what are the implications of giving sodium bicarbonate in shock? Okay. Uh, Paradoxical acidosis, IH, correct acidosis. So what are the implications if we look at this graph? Intracellular acidosis and decreased shift to left. Very good. Cardiac function will be better. Left shift. Yes, I think Dheeraj, yes, you are right. So what happens in shock? There will be metabolic acidosis, which normally shifts the curve to the right. Right? So that will help with oxygen delivery. But what happens when we give sodium bicarbonate? We are just trying to fix the pH, but we might cause a rapid shift of the oxygen hemoglobin dissociation curve to the left. So what will happen? Instead of releasing more oxygen, it becomes more and more difficult for oxygen to be released in the tissues where it is needed most. So we are here just correcting pH, but actually at the intracellular level, it may not help at all, because it will shift the oxyhemoglobin dissociation curve to the left, which will make the oxygen delivery very difficult at the level of tissues. So I think most of you were right with the identification of the curve P50, the factors which cause shift to right and left, but the implications of giving sodium bicarb, I hope everybody has understood now.
Yeah, I think that it's very easy to remember this shifting right and left by knowing that what happens at the tissue level.
Right.
The tissue metabolism will increase temperature, will decrease the pH, will increase the CO2, and will increase the 2,3-DPG. So it will shift the curve to the right. Okay. So all the factors which are related to metabolism will shift the curve to the right. And one more important thing to remember is, in the fetus is operating at a PaO2 of 27-28, which is P50. So that's useful to remember, because how the fetus drags the blood oxygen from the placenta. So Swati, good to go?
I think we can move to the next question,
Yeah.
sir.
So can I request everybody else to switch off their videos, especially I think Niranjan, Sayeda, Asra, and Neeraj Sharma. Is there any way, can we mute their videos? Pratima? Yeah, Neeraj also, because they're overlapping the slide. So, okay. So, while we are at the pathophysiology, let's look at this curve. All of you know this curve. This is a curve which is showing the dynamic compliance of the lung. So what it says here is that if you start with a low FRC, then the compliance is very poor. If you start at the optimum FRC, then your compliance is very good. And when you are at the high FRC, again, your compliance is very poor. So now the questions are, explain the use of TPs for delivery room CPAP in a newborn with RDS in relation to this curve. How delivery room TPs for delivery CPAP, TPs for delivery room CPAP helps in newborns based on this curve. Remember, you have to relate that to this curve. And what is C20 by C? What is the lower inflection point and what is hysteresis? So I understand people increase FRC, but why delivery room? Why not after 4 hours? Why not after 6 hours? It should increase whether you start in delivery room or later also, no? How is it that delivery room CPAP works better than CPAP starting few hours later? Relatively fluid absorption. Yeah, what happens? Correct. Baby lungs are wet at birth, so not really. Initial opening of alveoli just be to prevent collapse. Okay, so fixed control P, which is important when dynamic compliance changing. Yeah, I think you're partially correct, but the ideal answer is, so what happens at birth is the lung is filled with fluid. Okay, so the FRC is well maintained at birth because of the lung fluid. Now, when the lung fluid disappears, then what happens is this will collapse if there is no surfactant. Okay, if there is no surfactant, the lungs will collapse. But if surfactant is there, it will remain like this. It will remain like this with the disappearance of lung fluid. But when surfactant is not there, the alveoli collapse and the lung volume will come down. So the curve will shift from B to A in the absence of surfactant. So that is why CPAP will retain the curve at B and helps in preventing atelectasis and also keeping the good compliance, keeping the lung at good compliance or the optimal compliance or the steep portion of the dynamic lung compliance. Okay, so that's a correct answer. Some of you have told it, but I think ideal is to tell that with the at birth, the lung fluid is keeping the lung at FRC. But when the lung fluid disappears, if surfactant is, it will remain like that. But surfactant is not there, it will collapse. So opening a collapsed lung is difficult. You need more pressure. But if the lung is already there like that, then becoming opening and closing will become easier, as you can make out from this graph here. Okay. So now what is C20 by C? What is C20 by C? Yeah, I think everybody knows this. This is called beaking effect. On the graphs, you can see PV lobe. On the C part of the curve, you can see that when you see this curve, when you plot the ratio of this curve or the angle of this curve to the compliance angle, then you get the C20 by C. How much angle in the last part and how much angle in the steep part. That angle ratio is nothing but it is called C20 by C. Beaking means the angle should be ideally at least this angle should be 80% of the steep part. If this angle is less than 80% of the steep part, then that means there is significant beaking, overinflation of the lung. You may have to decrease the PIP or PEEP. What is lower inflection point? Yeah, correct. Many of you are correct. That is distension is correct. So what is lower inflection point? What is lower inflection point? Opening pressure point in compliance curve. Very good, very good. But how do we identify this? Clinically, how do we identify this? How do we know that we have reached the lower inflection point? Or how do we know that we have reached from this curve A to curve B on this graph? How do we know that we have crossed the lower inflection point? Yeah, Jitendra, what about tidal volume? Obviously, let us see that there is no PV low volume loop. Yes, one way is to look at the PV loop, that the curve goes straight like that rather than going up, going flat and then going up. If it is going flat and going up, you know that you have not achieved the Rover inflection point. So it is a point at which the flat curve becomes steep curve. That is the lower inflection point. But how do you know it? So this is very easy for you know that you keep the delta P constant. You keep the delta P constant and keep increasing the PEEP. So if the baby is having retractions and you have started ventilation, you keep increasing the PEEP and keep the delta P constant. At one point, you will see that when you keep increasing the PEEP, at one point you see that the tidal volume suddenly rises. That means for the same delta P, you are getting higher tidal volume. That means the compliance is suddenly increased. So, okay. So you can titrate the PEEP very well if you can use this principle of lower inflection point. If there are retractions, you keep increasing the PEEP and you keep watching the tidal volume. But ensure that the delta P is constant. If your delta P is constant and you keep increasing the PEEP, at one point you see that the tidal volume delivered will be significantly increased. That means the compliance suddenly rises. That is a point you say that, okay, I'm at the optimum FRC and I'm working on the steep part of the curve. Okay. So this is important to remember clinically, although many of you know what it means theoretically, but when it comes to practice, you should know how to use it practically. Okay. The other method is very simple method is when you keep increasing the PEEP at one point, you will see that suddenly the saturations become better and you will have a point at which you can decrease the FiO2. And that again is called recruitment of alveoli or opening of lung concept, where you keep the delta P constant and keep increasing the PEEP till you start seeing a drop in FiO2. And that point is a point when you have achieved your PEEP is above the lower inflection point. And what is hysteresis now? What is hysteresis and why is it there? Wonderful. It is a difference in tidal volume during inspiration and expiration. Not the tidal volume, it is lung volume. During inspiration and expiration, the lung volume. Curve do not overlap. Very good. They are not like this. So you'll always see that the curve is like this. So why is the curve like this? Obviously, this is the inspiratory, this is the expiratory. So for the same pressure, if you have on the x-axis the pressure, for the same pressure, you see that the volume is lower here compared to the volume here. Okay. Not the elastance. No, it is not surfactant. Very good. It is a resistance. So you all know that the resistance during expiration is higher than resistance during inspiration. During inspiration, the airways are wide. During expiration, the airways are narrow. So the resistive work of breathing is always higher during expiration rather than during inspiration. And if the lungs are not able to empty because of resistance, they'll remain at a higher volume. So it's like something like autopeep, which will always happen with every breath. So since the expirator resistance is higher compared to the inspirator resistance, for the same pressure which you are giving, your inspiratory tidal volume are always lesser than the expirator. And this concept is very useful during HFOV ventilation. So you would have seen that when we increase the MAP in HFOV, we'll increase the MAP to a point where your FiO2 stabilizes. And after that, if you see that if you increase the MAP little bit, then no further change in FiO2 will happen. So you keep increasing the MAP in HFOV till you see a drop in FiO2. Now that means you have achieved the point of optimum FRC. Now next thing you have to do is you have to drop the MAP by 1 or 2 points, because for the same pressure you will get the same. So for the lower pressure you will get the same volume. So when you decrease the MAP in HFOV, after seeing the drop in FiO2, you will not have any problem. So you can work on a lower MAP once you recruit the alveoli. So that's the concept of recruitment of lung or open lung concept, again in high frequency ventilation. Okay. So wonderful. So thank you. Over to you, Swati.
Yes, sir. So, I would like to narrate this case scenario. All of you, please see carefully. This is a preterm baby delivered at 29 weeks, female neonate, birth weight is 1.2 kg, and born to primigravida mother by cesarean section for the indication of severe preeclampsia. And the baby started having respiratory distress soon after birth, right? So it's a preterm baby who has begun to have respiratory distress soon after birth. So now tell me, any two drugs that can be given antenatally, or rather they should be given antenatally, that can improve outcomes in preterm babies. Yes, antenatal steroids, max self steroids, right? I think all of you are writing it correctly. Dexamethasone, magnesium sulfate, right? So as we all know that antenatal corticosteroids, such as dexamethasone, what do? They accelerate the fetal lung maturation, and there is enough evidence to show that it reduces perinatal and neonatal mortality, reduces the severity of RDS, and also the incidence of IVH. And how does magnesium sulfate help? In which in which women it should be given? Can anybody tell me that? In which expected preterm babies? Yes, 32 weeks or less. Yes. So 32 weeks or less, we have to give magnesium sulfate. Why it is given? It is mainly because it provides neuroprotection and reduces the risk of cerebral palsy and substantial gross motor dysfunction. Now the same baby, 29-weeker, 1.2 kg, as you all saw that the baby was having respiratory distress. So which scoring system will you use to assess the severity? And as I can see in the chat box, all of you have written it rightly as Silverman-Anderson score, right? So this is the appropriate scoring system that can be used in preterm babies, and basically it assesses 5 clinical signs: the lower chest retractions, xiphoid retractions, the synchrony of the upper chest movement, nasal flaring, and grunting. And it is very useful to objectively quantify the severity of respiratory distress. Yes. Now the next question is, can the same score be used in term neonates? Everybody is writing here no, no. Yes. Okay. Yes, Alpna, yes. Okay. So the same score, the Silverman-Anderson score, can be used in term neonates as well. However, Downey's there is preferred because it also tells us about the oxygen requirement, hence telling us about the severity of parenchymal involvement. So Silverman-Anderson score can be used in term babies as well. Okay, but the other way around, the Downey's score should be avoided in preterm infants, because assessing decrease in air entry, which is one of the important components of the Downey score, it is relatively difficult in premature infants as they have small chest walls. So the Silverman-Anderson score can be used in term babies, but avoid using Downey's score in preterm babies. So we can move to the next question.
Yeah. I think Pratima, can you unmute my video?
Oh, okay, okay.
Okay,
Just a
no
second.
problem. Yeah. So good. I think that question was easy for most of the people.
Yes.
Steroid and max self and SAS score, yes. But I think Downey score, as she said, is useful. Whatever be the etiology, what you should think is, if the problem is FRC, SAS score is useful. If the problem is something to do with hyperinflation or your PVR is high because of high lung volume, then Downey score will be useful, because there you will have to look at oxygenation, how much oxygen and how much FiO2 and things like that. So wonderful. So let's go to the next question. Again, I think almost the similar type. Now you have to do the scoring here. Can you hear the audio? Can you hear the sound of the baby? Say yes or no. No. Anyway, so if you're not able to hear, understand that you are able to hear the grunting in this baby. Okay. Now do a Silverman-Anderson score for this baby. So you can hear the grunting. If you can hear the grunting, do a Silverman-Anderson score in this baby. The baby has just come. Preparations are being done for starting CPAP and or other mode of respiratory support in this baby. I think most of you are correct. Yes. So you can see here, grunt already 2, nasal flaring is very classically seen. Another two, upper chest, you can see there is not seesaw, but there is some asynchrony of movement. So one, lower chest, you can see retractions in the lower part of the chest below the mid-axillary lines, and sternal retraction also some amount of self-restraint. So three here, two for nasal flaring and two for grunting. So total score is 7. Wonderful. I think many of them are doing Silverman-Anderson score looks like. So good, good. Now next thing is, what is the respiratory support which you will give in this baby? What is the best respiratory support you will give for this baby? Okay, so I think everybody knows, but there are one or two people who said mechanical ventilation. We don't agree with that. Any form of NIV is better, but in a country like ours, we'll prefer to give NIV over CPAP or bubble CPAP over nasal IMV, because nasal IMV requires a ventilator and a different circuit. So preferable is to give a bubble CPAP for this baby. And if you are starting bubble CPAP, what are the settings? So if you start bubble CPAP for this baby, what settings you'll start with? Wonderful. Good, 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 good. What about the third parameter? So wonderful. All of you are correct that you start with a PEEP of 6, or you call it a CPAP of 6 rather than PEEP. The rule of 5 doesn't apply now. There is a small change there. So, and you are all DNBs, so it is not for you people rule of 5. Flow is 5 liters is correct. Wonderful. I think many of you are correct that you start with an FiO2 of 30%. Remember that now, whether CPAP or ventilation, if there is lung disease, your starting FiO2 is always 30%. And flow should be 5 liters. Yes, and the PEEP is at least 6, because you are seeing moderate to severe distress in this baby. Starting PEEP is 5, in CPAP is 5 in babies of some distress. But if you have moderate to severe distress like this, I would prefer to start with a PEEP of 6. Now, how do you titrate the settings further? So flow of 5, PEEP of 6, and FiO2 30%. How do you titrate further? So how do you titrate PEEP or CPAP, pressure, and yes. So just relate both. So how do you titrate flow with what? CPAP pressure and FiO2 with what? Wonderful, wonderful. Okay. Flow. How do you titrate the flow? Is 5 flow uniform, or we need to see something? Wonderful. Very good. I think many people are already aware that if your flow is adequate, bubbling will be there in the bubble chamber. That means you have achieved the pressures in the circuit. Second is the pressure and FiO2. So for that, you have to look at the saturations. If your saturations are low, or if your work of breathing is high, you will keep on increasing the pressure till your work of breathing is reduced. So once your work of breathing is reduced, look at the FiO2. If FiO2 is, look at the saturation. If saturation is less than 91%, you increase the CPAP pressure if recessions are there. If recessions are not there, then you increase the FiO2. Okay. So in that order, you have to go. First is flow for bubbling. Second is recessions for CPAP. So keep increasing the CPAP pressures till you see a drop in recessions or SA score. And once your score is minimal, less than 3 or 3, and your saturations are still less than 90, then you increase the FiO2. Okay. So I think wonderful. I think all of you are aware of CPAP, and I don't think we can become a neonatologist without knowing about CPAP and CPAP pressures. Over to you, Swati.
Thank you, sir. So the next question is, I want all of you to look at these case scenarios. So consider the following two blood gas analysis of two ventilated term babies. Settings for both the babies are PIP of 18 centimeter H2, PEEP 6, and FiO2 40%. Now baby A and baby B's, the blood gases are as shown. And baby A is having a pH of 7.4, PCO2 38, PO2 45, and SaO2 of 85%. Hemoglobin is 7 gram per deciliter. Baby B has a pH of 7.3, PCO2 of 60, PO2 of 47, SaO2 of 80%, and hemoglobin of 10 gram per deciliter. Okay. So the question here is, what is the concept of arterial oxygen content? And I would also like you to answer that which of these babies is more hypoxic based upon the arterial oxygen content. So you can write down in the chat box at least the formula if you're aware. The arterial oxygen content. Baby B, how did you derive that? Okay, so somebody has written the formula. Baby B. Any more answers? B, then A. A is more hypoxemic. Okay, so let us discuss this. Now, both babies, as you see, they are on identical ventilator settings, right? And their PO2 values are also very similar. But however, when we think about tissue oxygenation, PO2 or SPO2 alone is not enough. The key concept here is actually how much oxygen or how much arterial oxygen content is, right? So what is arterial oxygen content? Yes, I can see somebody has written the formula correctly in the chat box. Basically, arterial oxygen content represents the total amount of oxygen carried in arterial blood. Okay. Oxygen is transported in two forms, as we all know, majorly bound to hemoglobin, and little is dissolved in plasma as well. Now, each gram of hemoglobin it carries can carry 1.34 ml of oxygen. So, hemoglobin bound oxygen is calculated as 1.34 into hemoglobin into SaO2, right? That gives us the oxygen which is bound to hemoglobin. A small amount of oxygen is dissolved in plasma as well, and that is quantified as 0.003 into PaO2. So, what is 0.003? As all of you have written in the answer, it is basically the solubility coefficient of oxygen in plasma. Okay, so adding both these components will give us the total arterial oxygen content. So the final formula is something like 1.34 into hemoglobin into SaO2 plus 0.003 into PaO2. Right? So what is the normal value of arterial oxygen content? Has anybody written in the chat box? So normally it is around 16 to 22 ml. Yes, I think Monica has correctly answered. Yes, it is 16 to 22 ml of oxygen per deciliter of blood. Right. Yes, Jitendra, Dr. Jitendra has also rightly mentioned. Dr. Gaurav, yes, yes, it is roughly 16 to 22 ml of oxygen per deciliter of blood, right? Now, with the same formula, when we calculate the arterial oxygen content of both the babies, we will see that baby A is having, what is the arterial oxygen content? Has anybody calculated? Yes, yes, very good. So baby A is having yes, I think correct. Dhamecha is the answer is right. It is around 8, and for baby B it is around 10.8. So baby A is more hypoxic because of the lower arterial oxygen content. Now the next question here is which would increase oxygen delivery more in this case? Just increasing the FiO2 or increasing hemoglobin by PRBC transfusion? Good. Yes.
Yeah.
I think most of you are writing transfusion. Yes, I think that's good because we just now saw that oxygen delivery is not only limited to PaO2, it also is dependent majorly upon the delivery of oxygen by hemoglobin. So if there is, we cannot deliver oxygen if there is nothing to carry it, right? So in this case, giving a PRBC transfusion will help in better oxygen delivery.
So I think that's a very useful concept for everybody to understand that in a baby with shock, in the order of importance, all are important, but in the order of importance, you should first take care of hemoglobin. Then you should optimize the circulation. And then you think if your ventilator management needs to be changed to improve the hypoxia. So you will always ventilate, but increasing FiO2, increasing pressure will not do unless your circulation and your hemoglobin is improved. So hemoglobin takes the major on high on the order, then circulation, and then comes the lung. most of us normally go, if hypoxic baby, acidosis, first we think of improving FiO2, but it's not the concept that you need to work on improving hemoglobin, bring it to optimize, then circulation, and then FiO2. Wonderful concept. Yeah. Thank you, Swati.
Thank you, sir.
We'll move
Next
to the
question,
next question.
please.
Again, you have a clinical case here. This baby is on the ventilator. You can look at the baby. There is an assist control mode of ventilation, maintaining saturations, heart rate of 140, BP seems to be normal. Now looking at his breathing, can you tell me what is the problem you are seeing in this baby? Just look at the breathing and let me know what problem you are seeing in the baby. Can you see Swati clearly this video?
Visible, sir.
Okay.
Hmm.
Yeah, I want to know what is the problem you are seeing, and I'm seeing the chat box open. So very good. I think asynchrony, wonderful. So that is the thing which obviously whenever looking at a ventilated thing, baby, the first thing we should come to your mind is whether the baby is breathing the ventilator or not. So here the baby is breathing at its own pace and the ventilator is breathing at its own pace. So there is no synchrony between the baby and the ventilator. Now the one, your identification is correct. Now let me tell us what are the reasons for this asynchrony. When do you get asynchrony between the baby and the ventilator? Go ahead. There are a lot of things which can happen asynchrony. Wonderful. Wonderful. Good. I think most of you are concentrating on condensation. Is the baby fighting here? Yeah, one of the reasons could be, but baby is not fighting here. You did not see any condensation in the inspirator limb. You saw that temperature displayed is 39. There is no water in the inspirator limb. This baby doesn't require any sedation, is not fighting the ventilator. Trigger, if you see, looks like all right because you're able to see that the graphs very well displayed. Wonderful. So mostly it is a tube. So remember that tube is the biggest problem for asynchrony. Most of them don't understand that, but tube size, tube position, and secretions. So here, the most likely problem. So as all of you said, it could be that you're giving inadequate pressures. So the baby is not getting adequate ventilation, but you see FiO2 is very low. That means it's not a pressure problem. Now, the second thing is, could it be a problem related to condensate? No, it doesn't look like that. So it is not fighting the baby. It is not some baby who is crying or having mismatch because of crying or pain or anxiety. So, but those are other reasons that it can be because of inadequate pressure delivery, or it can be because of inadequate settings, or it can be because of tube circuit problem or tube related problems. Now, from these, which problem is more likely in this baby? So we have already seen that it is not a problem with the ventilator. Yeah, wonderful. So what will you do to correct this asynchrony? What is the most important thing you'll do to correct this asynchrony? Wonderful, good. So I think partly you can also see in the graph that there is some amount of secretion present in the tube, but this early asynchrony, early tube block, you can see that some of the graphs, you can see there is air trapping which is happening. You can see in the third flow volume loop, you can see that it's not able to reach it 0. That means there is some amount of air trapping which is happening, probably because of the secretions. And you know that even a small decrease in volume will increase the resistance dramatically, and the volume doesn't come out, and baby can have auto trap also. So this is very important, and this baby has done wonderful after just doing a good suction. Okay. So this is asynchrony is shown, possible causes. Now comes one very important question is, what clinical signs you will use for adjusting PAP, PIP and FiO2? What clinical signs one should use to adjust whether your PIP is high or low? You want to increase the PAP, what will you do? You want to change the PAP, what will you do? FiO2. Wonderful. I think everybody knows this now. The concepts are very clear. Yes. So chest rise is this movement. Okay. Retractions, all of you know, look at the intercostal and subcostal retractions, and FiO2 is for SpO2. But before increasing the FiO2, you have to open the lung. You should get a gentle chest rise, not a chest like this, and you should be able to auscultate, and on auscultation, you should hear a gentle opening of the alveoli, which is like this. This should be the way the alveoli should open. It is not like this. So which means you are suddenly opening the lung. That is not required, and you are suddenly causing significant rise. So you can judge your lung volume, your PAP or your delta P by looking at the chest rise, and you can look at your PEEP optimization by look at retractions. And after taking care of retractions and chest rise, and again you don't want overinflation. If overinflation is there, you decrease the PEEP, and the chest is not rising. Sometimes it may be because of high delta P also. That is a peaking part. Then you have to decrease the PEEP and look at the chest rise. Okay. And after taking care of the PIP and PEEP, then only increase the FiO2 if your saturations are low. Now, next thing is name one graphical method to adjust the TA and TE. So how do you optimize TA and TE based on the graph? You have 3 graphs here. So which is the best graph? Yeah, wonderful. So all of you are right. That is a flow time scalar graph you will use to optimize TA and TE. How will you know that your TI is inadequate? How will you know your TI is excess? TI. How will you know your TI is inadequate and TI is excess? So from the flow time graph, how will you know your TI is excess? So nicely seen here. So what happens during inspiratory hold? So you can see here flow time graph, inspiratory flow, expiratory flow, inspiratory flow, expiratory flow. If there is a significant gap between the inspiratory and expiratory flow where there is zero flow time. So if there is a zero flow time between inspiration and expiration, then you know your TI is excess. You don't want too much time of zero flow between inspiration and expiration. So the gap between inspiration and expiration, you want it as low. Otherwise, what will happen is the baby is breathing like this, keeping the lung hold like that for long, which may help in atelectasis in the immediate phase, but that will also cause pneumothorax or air leaks. So there should be minimal gap between the inspiration and expiration if you're doing assist control or any other time cycle ventilations. How will you know your TI is inadequate? How will you know your TI is inadequate? Yeah, I think somebody have already done. Suppose the inspiratory flow, so before the inspiratory flow comes to zero, the inspiratory flow is not able to come to reach zero, suddenly the expiratory flow has started. That means your TI is inadequate. And when your TI is inadequate, your volumes delivered will be less, your pressure delivery will be inadequate. Okay, yeah, correct. Your inspiratory flow is not touching the baseline, means your TI is inadequate. Okay, now how will you know your TE is inadequate? TE is inadequate. So how will you know your TE is inadequate? So you need to increase the TE. Auto PEEP or rate trapping seen on the flow time graph. So how will you know that? So I think you can see in the second graph here that even before the expiratory curve, expiratory flow has come to zero, inspiration has started. So you should always have a gap between expiration and inspiration, but there should not be much gap between inspiration and expiration. The gap between the positive flow and the negative flow should be minimal. the gap between the negative flow and the next positive flow should be as long as possible, where you can sometimes see the spontaneous breath rate of the baby. So remember, these are very useful clinical clues for you to adjust your TA and TE, especially when you're doing time cycle ventilation. Over to you, Swati.
Thank you, sir. So, the next question is again a clinical scenario. We have a 1-day-old term baby boy being ventilated for meconium aspiration syndrome with PPHN on SIMV mode with high settings, PIP of 28, PEEP of 6, FiO2 100%, frequency 50, and MAP of 18 centimeter of H2O. So, ABG and radiograph is as given below. pH is 7.21, PCO2 58, PO2 52, bicarb 13, and SpO2 90%. So I can already see somebody has mentioned in the chat box need HFOV. So let me put up the questions first. But yes, you are right. The first question is interpret this blood gas. So these are the questions. You all can answer one by one. Interpret the blood gas. Calculate the oxygen index, OSI, AADO2, and respiratory index. Okay, mixed acidosis, right? I think everybody's right here. Yes, because it is acidosis clearly as we can see, and CO2 and bicarb are in opposite directions, so it is mixed acidosis, respiratory and metabolic. Now calculate the oxygenation index, OSI, AADO2, A by A, and respiratory index for this child. OI is 34, very good. How do you calculate that? So yes, MAP into FiO2 divided by PO2, very good. 35, right? I think all of you know the formula, right? So basically, why do we use oxygen indices? Why can't we just rely on PO2 or SpO2? So basically, PO2 or SpO2 alone, they do not account for the intensity of respiratory support that is required to oxygenate the baby, right? So what do oxygen indices do? They combine oxygenation with ventilator pressures, and thus they allow in more objectively grading the disease severity, right? So if we have two babies, both are saturating SpO2 100%, 100%, but one is on FiO2 of 21% and very low pressures, and other is on very high pressures, FiO2 100%. So there is a drastic difference between them. And the amount of work which we are doing to oxygenate the baby, that is actually reflected by these oxygen indices. So I think all of you have correctly mentioned the OI as 34 or 35. So what is oxygenation index? It is basically FiO2 into mean airway pressure into 100 divided by PO2. So basically it measures how much pressure and oxygen are required to achieve a given PO2. So higher the oxygenation index, worse is the oxygenation. So here the calculation is around 34.6. Now what is oxygen saturation index? Again, this is a non-invasive surrogate for OI. It is FiO2 into MAP into 100 divided by SpO2, right? Right. Dr. Jitendra has correctly mentioned it in the chat box. It's a non-invasive surrogate for OI, and it is useful when arterial access is limited. So suppose a baby is on CPAP support and arterial access is not available. In those conditions, OSI can be used. OSI, yes, correctly, as Dr. Gaurav has mentioned, the calculation, it is coming out to be 20, right? What is alveolar arterial oxygen gradient, AADO2? Has anybody calculated that? So AADO2 is basically what? It is alveolar arterial oxygen gradient, right? Yes, correct. Alveolar oxygen PaO2 minus PaO2, right? So what does it reflect? It reflects the efficiency of oxygen transfer from the alveoli to the blood. Okay, so a very high AADO2, what will it indicate? It indicates severe V by Q mismatch or an intrapulmonary shunt. So in this case, it is around 588. Okay. Now, what is A by A or alveolar arterial ratio? It is the fraction of alveolar oxygen that reaches the arterial blood. Okay. So normally A by A is more than 0.75. A low value will indicate severe shunt physiology. Yes, I can see somebody has written the formula correctly. Right. Good. Now, last one, the respiratory index, which is the severity of oxygenation failure with respect to the arterial oxygen. Okay. So it is AaDO2 divided by PO2. Yes, correct. It is AaDO2 divided by PO2. I can see in the chat box. I think many of you have correctly written the formulas as well as the answers. So very good. Right. So we have to remember this thing that PO2 will tell us the oxygen level, but oxygen indices will tell us about the severity of the disease. Now, what therapeutic intervention will you do in this baby next? Good. Okay, so basically, when we have a baby who has hypoxic respiratory failure, PPH and mass, uh, yes, I can see most of you are writing HFOV. So the first thing is lung recruitment. We have to make sure that the lung is recruited well. So here in this X-ray also, as you can see, that the lungs there, you can appreciate diffuse atelectasis, and the lungs are not well expanded. So we would like to do lung recruitment, and it can be done with the help of HFOV, and even surfactant will help here. It will help in lung recruitment because this baby is on a very high FiO2. Right, I can see somebody has written as INO next. So yes, once we have taken care of the lung recruitment, we have optimized the perfusion, we have made sure that the blood sugars are okay, there is no hypothermia, acidosis has been taken care of by oxygenation and perfusion, then only we will go to the next step, which is pulmonary vasodilators. Right, I think all of you are right on that. But only one thing which I could not see in the chat box is that nobody has mentioned about the surfactant part. So even though this is a term baby with meconium aspiration syndrome, but with such high settings, we can surely use surfactant for lung recruitment in this case. Now, what is the impact of hypercarbia on lung and brain? And what will be the indication of initiating INO and ECMO based on OI? Yes, brain. Somebody had written hyper. Okay. Yes, so basically, yes, right. So basically, in the lung, the CO2 hypercarbia will cause vasoconstriction. So pulmonary vascular resistance will increase, but in the brain, it will cause vasodilatation, which will increase the risk of IVH and brain injury. Right. So the effect of PCO2 is opposite in the lungs and brain. Now, what would be the cutoff for initiating INO and ECMO? As you have rightly said, OI of more than 15 to 20 and ECMO more than OI more than 40 would be the indications. Right. So we can.
Yeah, thank you.
Yeah.
So as Swati has rightly pointed out, remember that your first step in severe respiratory problem or severe distress first is to take care of oxygenation of by correcting other things like anemia, circulation, electrolyte imbalance, and also pain. So these should be first thing. Then try to recruit the alveoli. We have other methods of recruitment like surfactant and then HFOV if required. And last is the specific things, and lastly ECMO. So in that order is what we want you to go, and not say only HFOV or INO as the first line therapy if the baby is having respiratory severe respiratory distress. Okay, now I think this graph after that for everybody it is very simple. What are these? Just look at the graph first, and this is obviously related to the previous question. So what are these A, B, C, D, E, F, G? I think there is A, B, C, D, E, F. So what are these? You can name the things and then you can write what are they doing there. You can write what are they and what are they doing there. So yeah, so this is a graph which depicts about vasoconstriction and vasodilatation in the pulmonary artery, right? A, B, C. So you have to think about phosphodiesterase 5 inhibitor, then what promotes the synthesis of cyclic GMP. C is what is phosphodiesterase 3 inhibitor. D is what increases cyclic AMP levels. D and E both are working on increasing cyclic AMP levels. And F is ET, that is endothelin. So it is endothelin receptor antagonist. I think everybody knows this. They have been, I think, looking at this graph, I think, very often. So good. So now that finishes the first question. Now the other question, I think, which is popularized by Dr. Satyan is what is the rule of 20 and 60 for management of babies with PPHN or with inhaled nitric oxide? What is the rule of 60 and 20? Okay, yeah, starting and weaning of INO is right. Can you elaborate, Gaurav? I think you're all right. A is sildenafil. I'll tell in detail after this. What is the rule of 20 and rule of 60? It is starting and stopping, but 20 means you need 3 things in rule of 20 and 3 things in rule of 60. So OA of 20, yes. I'm surprised many people are not writing. This is a very popular rule by, I think everywhere it is there now. Any book or any journal you see, you'll see this. Yeah, at least weaning, somebody has written, yes, when the FO2 comes less than 60 or PaO2 is more than 60, and after 60 minutes for 60 minutes, you'll start to wean off INO. Wonderful. Jitendra, you're right for weaning. And for starting, I think somebody has written Ruby 20 ppm is correct. One more 20. OI 20 at 20 in 20 minutes. Wonderful. I think Rashmi got it correct. All the 3 things are correct. Yes. So what are the target saturations in PPH? And currently, what do you think are the current saturation targets? Preductal 85, preductal, postductal 70. We are talking about only preductal. Jitendra, 93 exact is difficult. Yeah, Gaurav, you are right. So I think 91 to 95 is the correct target. I mean, remember very simple that across gestational age, across lung disease, now it become uniform. That 90 to 95% is what the target should be. There was a time when we used to tell you that you keep its saturation target 95 to 97. But now clearly it is said that if you go above 95%, there will be free radical injury, and which indirectly will lead to later PPHN exaggerated. Now coming to the graph here, you can see here there are 3 molecules you should remember as far as vasodilatation is concerned: cyclic AMP, cyclic GMP, and endothelin. If the levels of cyclic GMP and cyclic AMP increases, there will be vasodilatation. If endothelin acts on the endothelium, then there will be vasoconstriction. So what you do in PPHN is you increase cyclic GMP level by preventing degradation, that is activating this phosphodiesterase inhibitor, so which is sildenafil. And you increase the level of cyclic GMP by synthesis increasing by acting on the guanylate cyclase, which is activated by nitric oxide. So now B is nitric oxide, A is sildenafil, and C is phosphodiesterase 3 inhibitor, which prevents the degradation of cyclic AMP, which increase level of cyclic AMP, which is nothing but milrinone. And D and E are prostacyclin and alprostadin, which are nothing but prostacyclins, and which are routinely used sometimes for opening of the duct, and they can also be used for PPHN. And the last is F is bosentan or any other endothelin receptor antagonist. So these are the drugs which you should know, that there are 3 molecules which you have to remember as far as PPHN is concerned: cyclic AMP, cyclic GMP, and endothelin. Okay. Yeah, this is the final thing. You can see sildenafil, NO, bosentan, prostacyclin, alprostadil, and milrinone. Over to you, Swati.
Yes, sir. So the next question again is a clinical scenario. We have a 2 days old, 28 weeks, 1 kg preterm baby who required ventilation for RDS and received surfactant. So all of you can see the ventilator screen here. Please note down the parameters, and all of you can also see the blood gas. The pH is 7.49, PO2 is 100, PCO2 is 28, and bicarb is 20. Okay, so the first question here will be interpret the blood gas. Good. Anything else apart from respiratory alkalosis, right? Look at the blood gas again. Yes, I think Mona Lisa. Yes, you are right. Respiratory alkalosis and hyperoxia. Right. Great. So everybody is right here. It is relatively easy. The pH is high, PaCO2 is low, and PO2 is also 100. So it is respiratory alkalosis with hyperoxia. And what has caused it? Probably. Can anybody point out what is the problem here? This is a 1 kg baby. Yes. Excellent. Yes, so basically the baby is being overventilated. If you see the tidal volume, it is around 7.5 here, which should be around 4 to 6 ml in this baby. So this has caused hypocarbia. Now tell me, what is the impact of hypocarbia in preterm babies? Hypocarbia, PVL, yes. Right. I think all of you are on the same page here. No, it's not. Somebody has written IVH. So basically, hypercarbia will cause IVH by causing cerebral vasodilatation. But hypocarbia, what does it do? It causes cerebral vasoconstriction. So it will lead to cerebral ischemia, and it will lead to PVL and not IVH. Okay. So it is PVL because of hypocarbia and IVH because of hypercarbia. Yes. Anything else hypocarbia can cause? Yes, it can cause hearing loss as well. Very good. Yes, so basically PVL and hearing loss. So therefore, hypocarbia should be really actively avoided in preterm babies. Now, what immediate step will you take in this case? Reduce and decrease PIP. Very good. Okay. So FiO2 is already, I think if you see on that display, it's already 21%. So decrease PIP. Yes, very nice. Okay, so all of you are right here. So we have to decrease the PIP and also assess the baby for readiness for assess baby's readiness for extubation. Right. First, we have to decrease the PIP to reduce the tidal volume. Yes, you can also put the baby in volume guarantee mode and set the target tidal volume and then ventilate. Good. Now, can volume guarantee be used with leak as shown above? I hope all of you noticed that the display was also showing some percentage of leak. Have you noticed? Can you see? Yeah, so can it be used? More than 40%. Okay. Okay. Up to 25% somebody is writing. So VG is misnomer. Okay, so I think I'm getting a variety of answers here. So basically, it becomes the volume guarantee, particularly if we see the older ventilators, VG becomes unreliable when leak exceeds around 40%. Okay, but in the newer ventilator series, particularly the VN series, there are leak compensation mechanisms which can take care of leak even up to 70 to 80%. Okay, beyond these limits, the delivered tidal volume estimation becomes very inaccurate, and that increases the risk of hypocarbia and volute trauma. So I think 40% is there for the older ventilators, and for the newer ones, even up to 70 to 80% leak can be handled by them. So name one drug to facilitate extubation in this baby. Caffeine citrate. Yes, correct. Yes, as we all know, all babies, particularly very preterm babies, less than 1.25 kg, peri-extubation, or even now we actually have gone away from peri-extubation. We start caffeine early in these babies. It helps in reducing apnea, improves the extubation success, and along with early CPAP and early surfactant, it also helps in reducing BPD. So I think with this we'll end the questions here. So we can take up the next question.
Yeah, I think again we are coming to the same similar
Yes.
concept here. There are two figures shown here, figure 1 and figure 2. Please have a close look at the figure 1 and figure 2. They are from the same baby. So what is shown in the figure 1 and what happened in figure 2? There was a small adjustment made and figure 1 became figure 2. Wonderful. Figure 1 is showing leak, correct? You can see that the inspiratory flow is not able to come down to 0. And you can see that the inspiratory tidal volume has not come to 0. You can see the inspiratory tidal volume has not come to 0. So there is a large leak in the first F1. But what happened? What was made? What change would have led to figure 2? Just one simple change has led to figure 1 has become figure 2. Tube change. Okay. TI, no, not TI, it is definitely leak only. All of you must be doing this. Sometime it is not default, you have to do that. Neck flexion extension will not cause so much change in the leaks. Maybe little change it can cause, but not so much. A tube change to some extent could be right, because if it's a very small tube and then you have changed, so it could happen. Sensor, not much change in the sensor here. So activate leak compensation. If leak compensation is activated, then whatever leak is there in the baby, peritubal leak can be automatically compensated. Yeah, correct. Sinha, Kalyani, you're right. This is leak compensation has been activated. So leak compensation was not activated. That's why you get a graph 1, and leak compensation is activated in graph 2. So I think everybody knows now what leak compensation is. Swati has already told us that up to 40% Olden ventilator, but in current dragger up to 60-70% also they are able to compensate for leaks. Now important is that leak compensation understood. Then what is leak adaptation? What do you mean by leak adaptation? Leak compensation is taking care of leaks for delivering correct tidal volumes, which the computer algorithm will see how much inspiratory expiratory leak and then makes a calculation, and based on that it will compensate the tidal volume. What is leak adaptation? Yeah, correct, Nivedita, but what do you mean by it? What happens by leak adaptation? Automated adjustment to leak flow, correct? So why if there is leak compensation is not activated, but leak adaptation will be there, and how it will help? How it will help? So what part of synchronization will it help? So I think nobody has been able to answer it so far. Not auto triggering. It will not trigger. If you have a leak, triggering will not happen. So leak adaptation will allow triggering. What will you do? So what happens is, suppose you have a flow, the flow has not become 0 and your trigger is below the flow. So your flow has not become 0, but the trigger is low. So obviously the baby will not be able to trigger. So work of breathing will be higher. So what the machine will do, trigger automatically bring it above the leak. So that is called leak adaptation. Now same thing, if you are having a expiratory synchrony, which is the flow is not able to come down to zero. So if you are not able to reach that 80%, suppose you have a leak and you are not able to reach 80% down from the peak for termination. So what will do, the machine will automatically titrate for the leak and bring it above, so that termination sensitivity also happens. So this is inbuilt. So you don't have to check for adjust for leak adaptation, but leak compensation you have to do, you have to activate in some of the machines. Okay, Swati, I think we are better. At least somewhere they are not answered.
Sir, somebody, sir, Dr. Gaurav, he wants to understand leak adaptation again, sir. He has mentioned in the chat.
Okay, so just go back to this graph. You see that, suppose you see here in the flow time graph, there is a leak. So your flow is not able to come to zero. Now the first graph says that the flow is still not able to come to zero and your trigger is at that level. So baby will never be able to trigger. So what the machine does, it will bring the trigger up so that the triggering will happen. So if it sees that the leak is above the trigger level, it will bring the trigger up so the baby can trigger every breath. Same is of the concept at the expiratory part. So you can see here that this will go as inspiration. In the inspiration, what happens is this flow will remain above positive always in leak. So, and if the flow is positive, after the expiration, the flow is positive. So if the flow is positive, triggering will not happen. So it will bring the trigger above that. Now, if you see here, suppose this is the leak here is bringing the flow to 70%. Okay, but your termination sensitivity is 80%. Now, obviously, the termination will not happen. So the inspiration will get prolonged. So one way is to have a TI time, which is the maximum time. After that time, expiration will start. But obviously, to compensate for that, what will happen is now the termination sensitivity will be brought above 70%. So it will brought 65%, or because it's already 80, they'll bring it above 70% so that every breath is terminated. It knows what is leak and what is a set termination sensitivity. Is that clear, Gaurav, now? Okay, thank you. So question D in, what is this? Comment on D question in OSCE 11. Where is D question? In OSCE 10. Target tidal volume. Huh? So it's almost fixed, 4 to 6 ml, no? Yeah. Over to Swati.
Yeah, thank you, sir. So this
Seema,
is
we
a
are
clinic.
okay on time. We have another 8 questions.
We have, I think, 40 minutes more, sir.
Okay.
So we have a clinical scenario here, a simpler one. It's a late preterm baby, 2.5 kg, respiratory distress soon after birth, and was noted to have frothy secretions. And the chest radiograph is as shown. Yes, I can already see in the chat box, all of you have written TEF. Very good. Yes. So the most likely diagnosis here is tracheoesophageal fistula, and we can see clinical scenario is there. The baby is having frothy secretions, respiratory distress soon after birth, and radiologically we can see that there is coiling of the tube. So the most likely diagnosis is TEF, right? All of you are right here, and you have mentioned the type also. Very good. So how do you know it is type C? Can anybody comment? Yes, you can see gas in the bowel. Good. So now list two antenatal findings which would raise suspicion. So one is polyhydramnios, very good, and yes, all of you are writing polyhydramnios. Another one, so absent or small stomach bubble. So absence of stomach bubble, yes. So antenatally, if there is polyhydramnios and there is absent or small stomach bubble, that should raise the suspicion for the presence of a tracheoesophageal fistula. Now, what factors are associated with poor prognosis? Okay, particularly which ones? CHT, good. Weight and cardiac, very good. Yes, weight. Okay, so I think most of you are writing it rightly. So weight less than 1.5 to 2 kgs and presence of a major congenital cardiac defect, they are associated with poor prognosis. Now, which associated congenital anomalies must be systemically screened for in this neonate? Vertebral, yes, I think that's an easy one. So vertebral, anorectal, cardiac, tracheoesophageal, renal, and limb anomalies. All the babies who have TEF, they must be systematically screened for the associated vertebral group of anomalies. Now, what is long gap esophageal atresia, and what are the implications for surgical and perioperative management? Okay, P centimeter, which cannot be repaired by primary repair. Okay, vertebral yes, two-staged. Yes. So basically, long gap esophageal atresia is defined as an esophageal gap of more than or equal to 3 vertebral bodies, and where primary anastomosis is not feasible at birth, right? So the implications also, I think most of you are getting it right, that primary anastomosis will not be feasible in most of these cases. So it has to be a staged repair. It can be a delayed primary repair where there is some time is given for the esophageal growth to happen and primary repair is done later, or it can be a staged repair. As I can see, somebody has written correctly, the esophagostomy and gastrostomy are done, and then at a later stage the repair is done. So I think most of you have got it right. So list 5 important complications that may occur during follow-up. Yes. So all the babies with a repaired TEF or esophageal atresia, they must be followed up by on a long-term basis by a multidisciplinary team. They can have a variety of complications, as all of you are mentioning correctly. Yes, they can have anastomotic leaks, strictures. There can be recurrent TEF. There can be dysphagia, GERD. Right. I think most of you are right here. Along with it, they can have the problems of the airway. So tracheobronchomalacia is also very common in post-op patients. Yes, tracheomalacia. Then chest wall deformities, scoliosis, and poor growth and some developmental delay. These are the things which we need to see during the follow-up of these babies. Over to you, sir, for the next question. I think most of them have correctly answered this question well.
Yeah, I think one more thing I think we should catch up antenatal is if you have IUG or polyhydramnios. It's a very useful combination to find that there is a malformation sitting there. The IUGR with which should be with oligo, but if you have IUGR with polyhydramnios, you should think of this underlying problem. Yeah, now we come to one more interesting part. So look at this before we go to the question. So you have something here on the x-axis, the temperature of the gas. In the y-axis, you have the absolute humidity. Now the questions are, how is humidity related to temperature? So how is humidity related to temperature? Now, stomach bubble is not absent in all babies because there will be some amount of lung fluid also coming to the stomach. How is humidity related to temperature? Increases with temperature is wrong. No, humidity is not directly related. No. You can see here, no? This graph doesn't tell you about relation. It tells you that how much humidity and temperature. Dew point. Yeah, I think it's a concept you should understand that with increasing temperature, the relative humidity will fall. So there is no way humidity can increase. When you increase the gas temperature, the relative humidity will fall. Why does it fall? Because from this graph, if you see, as you increase the temperature, the ability to hold moisture will increase. So if a gas is holding 20 ml at say 19 degrees Celsius, will be same gas will be at 37 degrees Celsius will be able to hold 40 ml of water per deciliter. So 40 milligrams of water for each deciliter of water, each deciliter of vapor. So this will tell you that when you increase the temperature, the relative humidity will come, and the relative humidity is nothing but whatever is the current humidity divided by what maximum it can hold at that particular temperature. So when you increase the temperature, the relative humidity will fall, and when you decrease the temperature, the relative humidity will increase. So this is the thing which you should tell. So I think nobody got it correct. So this concept is very important for all of you, that as the temperature increases, the relative humidity will fall, or you can say that the ability to hold moisture will increase. So humidity means whatever is gas present. So we always measure it as relative humidity. Now from this graph, if the baby is breathing at 19 degrees compared to a baby breathing at 37 degrees, okay, baby is breathing at 19 versus baby is breathing at 37. What is the volume of moisture needed to be added to the baby's airway if the baby is breathing at 19 compared to that breathing at 37? Temperature can help in holding moisture, correct? Increased temperature, greater capacity to hold moisture. You're right, Raja. How much of volume of gas we need, water vapor we need to add? So we have seen what is the from here 19 and 37. You can see the graph and identify. No Kalyani, no Paresh. I think all of you have to read humidity. Looks like not a popular topic, but I can tell you that humidity is the crux of respiratory management. No, Gaurav, it is not. It is not. Okay, Pradhan. Yeah, Pradhan, can you tell how it is 22? Pradhan, can you tell how is it 22? Mona Lisa. So yeah, I think we'll tell it about that, Paresh bhai, how we can achieve. We'll tell you. So if you see up this graph, on the x-axis you have the temperature and y-axis you have the humidity. This tells you that how much at what humidity or what water vapor the dew point will happen, and there'll be water condensation. Till the time you pour water, it will take on accepting as vapor. So at 19 degrees, it is 20 or maybe 19. At 37 degrees, what it can hold is 40, 44. So 44 minus 19 or 20, it is 24. So 24 ml per liter, 24 ml per liter of air need to be added by the baby if he's breathing at 19 degrees. So if you're keeping a baby in air conditioned room, the 24 ml of vapor has to be added, because from 19 degrees, the gas will become 37 when it goes into the body. Now that extra moisture has to be added by the body, and you see 20 ml per 1 liter of gas which the baby is breathing, that should be added for proper humidification of the airways. So this is very important for you to understand. If the baby is breathing air conditioning gases at 19, for every liter of gas which is going into the baby needs to add 20 milligram of 20 milligram per liter of gas which is going into the body. Okay. The third question is, why using dual water heater wire in the expirate limb is not good option in bubble CPAP? So we would not suggest to use a dual heater wire in the expirate limb in a bubble CPAP. No, it doesn't interfere with bubbling, because expirate limb water will fall into the bubble chamber. Condensation expirate limb compensate. Wonderful. Who is this? Yeah, Dr. Aparna, you're absolutely right. Aparna Balagopal. No, it has nothing to do with resistance because we are talking about expiratory limb and not of the baby. It is in the circuit, isn't it? I think Jebin correct. So normally what happens is because of the bubbling, there will be evaporation. So the water level may come down. If the water level comes down in the bubble chamber, the pressure delivered to the baby will be lesser. So when there is water condensate in the expiratory limb, drop by drop, it will fall into the bubble chamber and will compensate for the evaporative losses which happen in the bubble chamber. It will never increase the level because when the level increases, it goes into the side chamber and excess water will fall into the side chamber. Okay. So avoid using heater wire in the expiratory limb whenever you're using bubble CPAP. Why is passive humidification not an option in newborn? Why, like adults, they have a HME. Why we are not using HME in newborns? Excessive resistance, not resistance. Yeah, it could be resistant because you're using a HME filters. Not really dead space. Expired gases may enter again. Okay. Doesn't happen like that. I think everybody has to read humidification. So wonderful chapter in Goldsmith. All of you should read that humidity chapter. Each and every word of Goldsmith is very important for humidification. So it is because of the increased rate and low tidal volume. So in adults, what happens is low rate and high tidal volume. The gas coming out is able to warm the gas which is going into the body. But since the baby's rate is very fast, and the tidal volumes are very small, the volume coming out is not able to compensate for the humidity of the gas coming in. First point is that low tidal volume and increased rate. Okay. So I think nobody could get it correct except for the dual wire. I think all of you have got wrong. So need to read the chapter in Goldsmith on humidification. And also ventilation book also, you can buy a module on ventilation book and read it also. It also has all these concepts. Okay, over to Swati.
Here we can see question. Yeah, so all of you can see a graph on the screen. So identify the graph and what phases of respiration are depicted by A and B. You can type your answers. What is this graph? Okay, it is CO2, right? What it is called? Capnograph. Very good. And what phases of respiration are depicted by A and B? Yes, I think all of you have got it right. It's a capnograph, which is displaying the exhaled carbon dioxide concentration over time. Okay, so what phases are depicted by A and B? So A is inspiration and B is expiration, right? So A, where we can see the CO2 levels falling down to 0, that is during inspiration, and during expiration, the CO2 levels rise again, and then there is a plateau. That plateau at the end actually denotes the EtCO2, and then when inspiration starts, the graph falls down again. So I think, yes, all of you are right. It's a capnograph. A is inspiration, B is expiration. Now look at the graphs 1 and 2. And what abnormalities do they indicate? And also name any two neonatal conditions each associated with these patterns. Okay, so but what it is, bronchospasm is okay, but what abnormality do you see? Okay, fin shaped. I think yes, Jebin has correctly pointed it out. It's fin shaped, but what fin? And what is happening in the graph? Okay. Yes, so basically the first graph is what is it showing? It's showing a slanted upstroke with a prolonged expiratory phase, and that is producing the classical shark fin pattern. Okay, this indicates increased expiratory resistance, which we can see in bronchospasm, as somebody has said. Yes, in tube block and in meconium aspiration syndrome in BPD. Okay, now but in tube block we will not get this sort of capnograph. Okay, there may be loss of signal, which is actually there in the second graph. So second graph, if you see, there is sudden loss of waveform. Okay, this can happen when any two conditions. Tube displacement, very good. So either accidental extubation or tube displacement has happened, or the pulmonary flow to the lungs, the blood flow to the lungs has stopped suddenly, which can happen during cardiac arrest. So accidental extubation, circuit disconnection, or severe reduction in pulmonary blood flow can lead to sudden loss of waveform in the capnograph. Yeah, I think it is clear now.
Okay.
Mm.
So thank you. So again, a humidification question. So I didn't think they'll have to do a lot of reading here on the humidification. You can see here, there is a respirator. You have an inspiratory gas coming, humidifying the inspiratory circuit and baby. You have the expiratory limb. The flow of gas in this circuit is 5 liters per minute. Now, what is the question is, what is the water requirement? What is the water requirement for humidification in ml per hour if the temperature of exit, that is exit at the humidification chamber, is 37? And at 37, we know absolute humidity is 44 milligram per liter. So you can just write the formula also, it's correct. So what happens to what is the water requirement? Can we calculate the water requirement? 5 liters per minute is the flow, and the temperature exit is 37, and absolute humidity is 44. Assume that the gas coming to the humidifier has zero humidity, because the compressed gases do not have much of humidity. Nobody here? Nobody is even trying. It's very simple here if you know the concept. So what it is saying is humidity of, you need to add 44 milligrams completely, because inspiratory limb there is nothing. Somebody's calculated 220 ml. No, you're wrong. So you need to add 44 ml per liter. Okay. So how many liters is there? 5 liters. So 44 into 5 is, so 220 ml per minute. Per hour it is going to be, and how much is going to be per hour? Into 60. So 220 into 60 will be milligrams, and you have to convert that into grams to say into ml. I hope all of you understood that. So 220 milligram, wonderful. So I think Paresh bhai, you are right. Water will be, so 13.2 ml per hour. Wonderful. So you can now go back to your incubator, your humidifier, and see what is the flow, what is the temperature, and how much water will be required. So you can actually see how much water is required in the humidifier chamber. If you know the flow and if you know the temperature exit, you can actually, and use that previous graph at what temperature, what will be the humidity. And inspirate, obviously gas coming to the chamber doesn't have any humidity, but gas exiting has a humidity of whatever be the, it will be have absolute humidity of whatever is for that temperature. So all of you can go back and do this calculation by the bedside and see how much water will be required for hour, for the day, and see whether it is happening correctly or not also. So what happens to a relative humidity in the inspiratory limb? In all humidifiers, what happens to the relative humidity? What happens, I said, no relative humidity. What happens to the relative humidity in the inspiratory limb? So at exit from the humidifier chamber, relative humidity is 100% and temperature is 37. Again, I think everybody's gas flow will increase, temperature but decreased, relative humidity. I think, who is this? Absolutely wonderful. I think Paresh bhai, you have read little bit about, I think, humidification, right? So what happens is relative humidity decreases. Yadav, you are right. Pradhan, Mona Lisa, correct. So in the inspiratory limb, so you have at the exit 100% relative humidity. In the inspiratory limb, there is an increase in temperature from 37 to 39. When the temperature increases, the absolute humidity or the ability to hold water vapor will increase. So the relative humidity will drop because there is no vapor added in the inspiratory limb. So relative humidity will drop till the point where your temperature probe is there in the inspiratory limb. From there on, there will be a drop in temperature. Again, relative humidity will increase. So the correct answer is the relative humidity will increase till the temperature probe in the inspiratory limb. And from the temperature probe till it goes to the patient, again, relative humidity will increase. So there will be a drop and there will be a rise. And if the temperature matches, exit temperature humidity, humidifier to the temperature going to the nose matches, then at nose, the temperature, again, the humidity will become 100%. How does water in the circuit, especially the inspiratory limb, affect assist control mode of ventilation? If there is, wonderful, I think everybody knows this, auto triggering. So whenever there is respiratory rate is displayed is 70, 80 and baby is breathing at 30, so you should know that there could be water in the circuit and which can cause auto triggering. Wonderful. Okay, but anyway, I think all of you have to read the humidification chapter because that is a crux of respiration. Over to you, Swati.
Yes, sir. So again, I think all of you can see these two graphs on the screen. So have a look at both the graphs, and what does the area ACD 0 and A represent in figure 1, ABCA in figure 1, and what does the slope AC represent, and what does figure 2 depict? So all of you have identified the loop. And you can write down the answers. AC compliance, okay. What about the areas under ACD0A and ABCA? A is what A? So no, not resistive work. Okay, work of breathing, but I have specified the areas of the graph, areas of the loop. So ABCA represents different type of work of breathing and the other one different. Inflation point, no. Okay, so basically this is the PV loop as we all know. Work of breathing, figure 2 leak. Okay, so this is a pressure volume loop. We all are aware of that. And the area in the first figure, if you see ACD0A. So that is basically work of breathing which is required to overcome the elastic forces. Okay, so it depicts the elastic work of breathing, right? And ABCA is, yes, inspiratory work of breathing, but it is the work of breathing which is required to overcome airway and tissue resistance. So ABCA is actually the resistive work of breathing. And the slope of the curve AC is compliance. As we can see, if we have a PV loop which is sleeping, that means the compliance is low and the lung is stiff. If we have a graph which is standing, that means a steeper slope, that means the compliance is good and the lung is easy to inflate. Now what does figure 2 depict? Leak. Yes, I think all of you have got it right there. So how do you know it is a leak? Yes, it doesn't come back. So there is failure of expiratory limb to return to the starting point. So this may occur in leak, right? I think we can move ahead, sir.
Thank you, everybody. And I think we have few more questions. Yeah, this is now after that. So I think this should be everybody easy. Just write what is A, B, C, D, what is B, C, D, E, F. So just, I think after that, it should be very easy. What is B? You can see here, the down is inspiration, up is expiration. What is A, B, C, D, E, and F? Exhausted? I don't see any answers coming. Difficult, huh? Okay. A is okay. B. A is normal, correct, very good. Sunil, good. Yeah. B is expiratory resistance. What about C? Bronchoconstriction, obviously it's lower airway, cannot be both. Uh, C is what? C is fixed airway, very good. A is normal, B is restriction, C is obviously complete airway obstruction, upper and lower. What about D? Yeah, E is tracheomalacia, wonderful. E is tracheomalacia because it's a pliable thing. You can see that the pressure is changing. And E is very simple. Why nobody has written E? E is everyday affair, no? Wonderful. Water in that endotracheal tube or secretions. Okay, good. So I think B is expiratory flow limitation, that is expiratory obstruction. C is fixed because both are narrowed. So that is like the subglottic stenosis or upper airway obstruction. C is inspiratory flow limitation, which is tracheal or lower airway obstruction. E is unstable, as you see in a lot of variation, like in tracheomalacia and or bronchomalacia. E is water in the circuit. Okay, good. Over to you, Swati.
We have another flow time waveform now here, ventilated term neonate with meconium aspiration syndrome, and the flow time waveform is as shown below. Yes, I think Aparna has rightly mentioned already that we can see air trapping here. Yes, so identify the abnormality. There is air trapping. And what is the underlying mechanism? Okay, short TE. Insufficient TE. Excellent. Yes. So basically, your inspiration is starting before the expiration has ended, and it can happen if the respiratory rate is very high or ta is short. The inspiration will begin before the expiration has ended, and there is insufficient time for the lung to empty completely. Okay, so inadequate te will lead to such type of air trapping. And which conditions, which ventilator parameter will you adjust first here? I think it's easy. Yes, so what will you do? You will increase the expiratory time, you will reduce the respiratory rate and increase the expiratory time, TE. And what complication may develop if this is not corrected? So,
I think TE decreasing is
yes,
wrong. You have to decrease the rate or increase TE.
increase,
Some
yes.
people have written
Some people have, yeah,
increasing
and some
TE.
people have written
Yeah,
TI also. So I think
yeah.
that also is not appropriate here. The
Yes.
right answer will be to reduce the respiratory rate and increase the expiratory time. That is the right answer. So please note, all of you. Somebody has written TI increase also.
I
Okay,
think there
what
is a myth that in MAS you have to keep high rate. So MAS requires very low rate
low
because you
rate?
have to keep your TE very
Long.
significantly long so that there are a lot of airway resistance.
Right. So what complication may develop if this is not corrected? Pneumothorax can happen, right? Anything else? So there will be dynamic hyperinflation. It can lead to air leak. Because of hyperinflation, what will happen? There will be raised intrathoracic pressure, which will lead to reduced venous return. Yes, somebody has rightly pointed out decreased venous return, and it can, worsen the hypotension. So it can cause hypotension, air leaks, and rising PCO2. Sure,
Wonderful.
good.
So I think Swati, you can
Okay.
continue, I think.
So again, this is another case scenario. We'll do it quickly. It's a term one baby, day of life 20, persistent tachypnea, and radiograph is as shown. I want all of you to have a look at it closely. Yes, I think Aparna has already answered. Most of you are right at it. It is CLE. Yes, so what makes you give the diagnosis of CLE, and what would be the closest differential diagnosis here? Anything else? Okay. Pneumothorax, right? Yes. So basically, the diagnosis here is congenital lobar emphysema, and I think one of the closest differential will be pneumothorax. In fact, many times the CLEs are interpreted as pneumothoraces, and then a tube is inserted, which can actually worsen CLE. But there are certain points which can help in differentiating CLE from pneumothorax. What are they? Can anybody tell how will you differentiate between CLE and pneumothorax? Lung markings, very good. Lung border. Okay, so basically pneumothorax will show absence of pulmonary vascular markings, and in congenital lobar emphysema, the vascular markings are present, although they may be attenuated. And which investigation will you do to confirm the diagnosis, and what is the definitive management? CT, yes. So CT thorax will be done. And what is the management? Yes, so for asymptomatic or milder cases, conservative management and observation can be done. And in symptomatic cases, a lobectomy is usually done. I think we can move ahead, sir.
Yeah, thank you. So, yeah, with one of the last questions, last two, I think, yeah. Look at this. You can see something here, I'm sure. Some of your, what is shown here? Wonderful. I think already some people know about this. This is neurally adjusted ventilatory management. Okay. So this is NAVA. How does one measure the respiratory efforts in this mode? So ED current or ED signal. You can see the downmost part. The top four are the ECGs. Then the esophageal, when you put the esophageal probes, it has multiple electrodes, and these electrodes are 4 electrodes are there. They're picking up the ECG. So from the heart, these electrodes are used to position the esophageal tube, which should go into the tummy. So in that there are two ports. One is for the feeding. The other is it has the ECG leads. Okay. Now one of these ECG leads are also measuring the current, the electrical activity of the diaphragm, which is called eddy current. Now one measures the eddy current from the electrical activity, and in this there are two eddies: eddy minimum, eddy maximum. So what you should understand about eddy minimum and eddy maximum? If eddy max is increased, what does it mean? Increase eddy max means what does it mean? So yeah, increased diaphragmatic activity or increased diaphragmatic, so that means the brain wants more diaphragmatic activity. It wants to contract the diaphragmatic much more significantly. That means you are under ventilating. So or the lung disease is very severe, or there is a severe airway obstruction. So it's not able to inflate the lungs. So the brain is telling that I'm not getting adequate volume of gases. So kindly improve the lung volume. So that's why the eddy current will increase. Increased eddy current is a marker that the lung is unhealthy or the lung is not opened up. So if you have very high, the ED minimum is very high. What does it mean? Baseline itself is very high. Very good. I think Paresh Bhai read everything. Wonderful. Eddy minimum is high means low PEEP. That is mean at the beginning only the diaphragmatic activity is very high, which means it's trying to keep the alveoli open. So if it is not able to keep the alveoli open, then the eddy minimum will be increasing. So you have to remember two numbers here, 20 and 5. Eddy minimum should not be more than 5. Eddy maximum you should try to avoid more than 20. If eddy maximum is more than 20, definitely you need to increase the ventilatory settings and or NAVA level. And if eddy minimum is high, then you increase the PEEP. Okay, good. So that's all. Yeah, over to you, Swati. I think one more we have. This is the last year. Yeah, for AD peak target is 5 to 15, but keep it below 20 always. More than 20 means the lung is very bad. Oh, you can't hear Swati. I think you are muted.
I'm sorry, sir. Yeah. So it's a term-born baby, 3.2 kgs, maternal GDM on insulin, and second day of life, the baby has been having respiratory distress since birth. So all of you are able to see the X-ray, right? So what are the radiological findings here? Okay, good. So ground glass whiteout, yes. So we can see bilateral diffuse homogeneous opacification, which is giving the classic whiteout appearance. Anything else? Radiological findings, do you only see the lung part? Anything else do you notice? So when you are asked radiological findings, so can we go on the previous slide, sir? Yeah, so what else do you see here? Yes, ET tube deep. Anything else? There are two more things which are seen here. Okay, so it's an umbilical catheter, which is at what position? T10. Okay, good. Great. And you can also see a OG tube in situ, right? So whenever you are asked the radiological findings, you have to tell about all the interventions as well, whatever you are seeing on the radiograph. So we have whiteout lung. We see an endotracheal tube, which is deep, as somebody has already pointed out, it is at T4. So what should be the ideal position of endotracheal tube on a radiograph? Okay, T1 to T2. Yeah, so T1 to T2. Anything below T3 is definitely deep. So here it is at T4, it is little deep. And yeah, so next question is, in the term neonate like this, list 3 important differential diagnoses for this radiological appearance. Yes, so one would be very important, that RDS, particularly here in this setting, because the mother had gestational diabetes mellitus. So RDS is definitely on the top. Others can be GBS, very good. Anything else? Okay. Other than that, TAPVC. I think somebody has rightly mentioned TAPVC. So whenever we are seeing whiteout lungs, especially in a term baby, we should always think about TAPVC also. So RDS, pneumonia, sepsis, particularly GBS pneumonia, obstructed TAPVC, and certain surfactant deficiency disorders can give rise to this sort of picture, right? So which two rare surfactant dysfunction disorders can present in term neonates with this radiological appearance? Protein B, okay. Yes, alveoloproteinosis. Okay, so it is surfactant protein B deficiency and ABC3A deficiency. Okay. And what will be the clinical clues to surfactant deficiency disorders? This is very important. So when will you suspect, when will you start suspecting surfactant deficiency disorders in such babies? Okay. Yes. Anything else? Persistent distress. It's not improving after surfactant. Okay. High requirement. No improvement. Okay. Anything in the history part? So there may be a history of neonatal deaths, history of previous baby. Very good. Fetal loss. Siblings, yes, I think previous sibling death is something which is important. So, family history of neonatal deaths, a lack of sustained response to surfactant, and absence of infection or a cardiac disorder should make you suspect surfactant deficiency disorders. Right.
So we are to the last question. I think we are dot
On
on
time.
time. So again, coming back to Nava, what does A, B, C represent? What is A, B, C? I think nobody has seen Nava or read Nava. Anyway, we will want you to learn Nava because it's more a theoretical. Currently, it is not used in any of the units in the country. I'm not very sure if somebody is using, but yeah. So if you are looking at Nava, the down more part you get the eddy current, which is the diaphragm activity, and the ECG leads will tell you that whether your catheter, esophageal catheter, is in place or not. What you have to see is from the top to bottom, the QRS waveforms will decrease in amplitude. You can see here how it is decreasing in amplitude. And the other thing is P waves will disappear. So you can see the tall P wave and the lowermost ECG lead will not have any P wave. So you can see here on the reference also, you can see the topmost from the top to the bottom, you will see that the QRS will become small and small and the P wave will disappear and you get a good eddy current. Now here what happened is your tube is too high. So eddy current is minimal, not able to pick up. And you can see that the transition is there, but you are not on the fourth graph, you can't see any ECG only. So which means it is too high. And in the last one, you see it is all the waveforms are there, but even on the lowermost, you can see the P wave. That means you are too much deep inside. I think that's all. Thank you, one and all. So over to you, Pratima.
Thank you so much. I think such a comprehensive OSCE on respiratory system, sir, and Swati. A lot of conceptual questions and clinical based also. Any other queries from participants? You can type or you can unmute and ask. Any key take home, sir? What all should they be?
I think although a lot of questions were based on the graphs and on the some of the equipment, I would always want all of you to learn more about how to look at the baby, whether it is in distress assessment, whether management with CPAP, ventilation and different modes of ventilation, and also think of correcting the problems beyond ventilator. Learn to correct the problems beyond ventilator whenever you are using any respiratory support, because if you look at physiology, we've shown you how hemoglobin, how circulation will help more than taking care of only ventilatory parameters. And the graphs are going to only help you to understand the complications and adjust the setting rather than they leading the show. So you should use the graph to help you analyze and also adjust the setting babies based on the baby's findings. And you need to understand some complex things like compliance, resistance, the PV loop, the flow time graphs for understanding the lung disease also, and also for practical implication of these in the NICU. So I'm sure there was a lot of learning for all of us also. I think both Swati and I have learned a lot by this OSCE, and
Yes,
we thank
absolutely.
Association of Neonatologists of Delhi for giving this opportunity. And every OSCE is a learning. It's the best learning for the faculty as much as for the students.
Can we take just one question and then maybe we can discuss in the WhatsApp group later on also? I think last figure they want some clarification, sir.
Figure
Okay, I
A.
think so. A is normal. So you see that the ECG leads, the QRS will keep coming down, will not disappear. And you'll see a eddy current, which is smooth. If you have the QRS, which is you're not able to see the lower down the QRS, means the tube is too high. And if you're able to see all the QRS, but you see that the pattern is lost or the P wave is still there, because at the lowermost P wave should disappear. So if it's still there, means your tube is too deep inside. Okay.
So any resource material for reading Nava, sir, the latest or the recent advances?
I think there is a chapter on Nava in Goldsmith. If you read the chapter, I think it's wonderful. And I think most of them were weak on humidification, which is very, very useful for practical management. I think all of you go back and read humidification chapter in Goldsmith. And also there is a book by us published in Noble, which is on practical learning module on neonatal ventilation. So most of the practical aspects are already discussed there. So either buy a book on Goldsmith or ventilation module, published from Noble.
Okay, thank you, sir. So we plan to give 5 to 7 questions by tomorrow morning, dear all students, based on today's class itself, and we'll score you as per that, just to have a recap and a revision of today's session. So please do attempt those on Google Form, and we have top 5 performers from this session also to announce. We'll announce them in this week in the group itself. Thank you so much, Murki sir. Any questions in the group? We'll trouble you again, sir.
Sure.
Uh,
Thank
yeah,
you.
there's a
I
WhatsApp.
think only few people are interacting. I think
Yes.
everybody should try to attempt, because there is only learning when you start attempting. So make mistakes, no problem. Nobody is going to scold here or judge you. So if you make mistakes, you will learn. And if you attempt, you will learn. Thank you, Pratima.
Thank you, sir. Swati, any words from you before we conclude and close?
I think, ma'am, it was as I said, I think more and more students should interact. And one thing is that understanding physiology is as important as understanding therapies. So we should always try to look at the baby as a whole. That is one important message I would like to give to all the candidates. That's all, sir.
Yeah, we'll share the slides. I think they are going to share the slides. Isn't it? We are sharing the slides, Pratima, with the
Yes,
group.
sir, yes, sir, yes, sir. We'll share the recordings with all of them, the live recording as well as the.
Somebody wanted the ECG again. So we'll share the slides. You can look at that, and then you can also go back and see if there is anything wrong from our side. Let us know. Thank you.
Thank you, sir. Thank you. Thank you, Swati. Thank you, sir, again. And thank you, all the students. We'll meet you next Sunday, same time, 5 p.m. Thank you, sir. Thank you.
Thank you.